Hello friends, myself Dr. Himani Prajapati. I'm Assistant Professor at LG Institute of Physiotherapy. Today we are going to talk about a very interesting topic, that is the management of cerebellar ataxia. So before I start this lecture, there is very important point that I have to tell. First is, when the patient is having involvement of the deep cerebellar nuclei, then the prognosis is always bad in such cases. And second point, the use of weight cuffs to decrease the intentional tremor in these patients is no longer used, right? So these are the two most important points that we have to make sure before we deal with the cases of cerebellar ataxia. Now coming to the management, general aims will be to counsel the patient, to improve the static and dynamic balance, to improve coordination, to prevent secondary musculoskeletal problems. Mostly these patients suffer from genu recurvatum because the cerebellum is mainly responsible for the unconscious control on the posture. But because of this lack of this unconscious control, the body will adapt that position that is not aware of it. So patient usually have genu recurvatum, right? So we have to look for that, and usually the patient have foot deformities and knee deformities and everything. So we always have to look care for the secondary musculoskeletal problems. Last will be general conditioning to minimize the fatigue. So keeping in mind, we have to make the protocol in such a way that it should be sufficiently and increasingly challenged to facilitate the plasticity in the nervous system. Because if the patient is able to go for seated activity independently, then our main aim should be for all the standing independent activity, and later on all the gait activities, all the independent activities that he can be performed, right? So it should be like such challenging that it allows the neuronal firing and it allows the change in the nervous system, that is the neural plasticity. So plans, the short term goals will be to improve the static and dynamic balance, to improve the conscious control on posture, to improve dual tasking, to reduce movement decomposition, to improve coordination, to improve aerobic capacity, to make him fully functionally independent in open environment. So all the protocols we are giving, and whatever the gain in the all the activities we are having, this all in the closed environment. So our main aim should be the patient should be functionally independent in the open environment. Long term goals will be to decrease the tremor by gaining conscious control and improving self confidence, to improve the fine precision activities of upper limb, to improve gait, which is utmost important. And next will be to make him independent in the instrumental activities of daily living and the electronics activities of daily living. So uh, here there is one important protocol, that is chair yoga. Chair yoga is considered as an emerging protocol in the cases of neurorehabilitation. So we can start with the seated posture, that are cat and camel, trunk twisting, utkatasana, that is considered as sit to stand activities, right? And there are many of the postures, like here I have mentioned, that is the third one, that is urdhva baddha gulyasana, right? So there are so many postures that we can add on this for the improvement in these patients. Next, this chair we can use as a prop, and we can use as a standing activities, which will increase the confidence, balance, and strength. The activities which we can incorporate can be chair lunges, chair one leg standing, chair stepping movements of lower limb prior to gait training, right? So this stepping movements will be in basic support for all the gait training that will encourage later on in the patient. Static stance. We can use activities like standing feet together, unilateral stance, and standing on foam. Make sure that the progression is always from eyes open to eyes closed. Progression can be increased by time. Progression can be keeping arms across chest while doing activities. Progression can be feet apart to feet close. So it can be like changing the base of support and everything. Dynamic stance, we can work on kneeling and half kneeling reach outs. We can also use the vestibular ball. Standing toe taps, that can be in any direction, like forward, backward, to the side. We can progress to the alternating legs and everything. Next will be standing 360-degree turn, that is rightward, leftward, and this all will have same progression, that will be from eyes open to eyes closed. Next we can go with this standing reaches, right? Standing bends to pick up object from the floor and all the transitioning activities. So here all this balancing activity, we are using this as a tool for the assessment. Like we are using a standing bends to pick up object from the floor in bug balance score sheet. We are using standing reaches and dynamic gait index in bug balance scale and everything. So we can use this protocol as for the assessment and this protocol for the management also. We can also go for modified tug, which also involves the cognitive element. So we can improve the dual tasking also while improving the balance. So this all activities can be incorporated, right? Next will be coordination. In that we can go with the all the activities with commands, so this will improve the coordination, right? So all activities we have to go with the proper commanding, and with, like we can use with command foot tapping. We can make certain circles, and we can ask the patient to appropriately put their feet whenever the number is asked, right? So if one number is asked and it is on the right side of the patient, then instantly the patient should tap the foot in the right direction. So that's how we can go for all the activities for coordination. Next will be the gait training in the parallel bar. Here very important part is gait training with perturbations, right? Perturbations can be two types. First will be the self-imposed and next will be the external. So if while the patient is walking and if I'm giving perturbation from the backward side, so the patient should be that much able to activate all the feed forward mechanisms to again gain the base of support. So that's how we can work on the balancing activities and the gait training. Next will be the obstacle gait training. So we can go with putting cons while the patient is walking. Next we can also go for dual tasking with cognitive task. As I have mentioned for the modified tug, here also we can go through it, right? So this is all a basic rehabilitation protocol. Very important part is gaze and eye movements. Patients of cerebellar don't just have the balance issues; they also have nystagmus problem, because cerebellar nuclei, very important is the fastigial nucleus, cerebellar all the pathways, then vestibular system, and then cerebral cortex. These are having a highly interlinked neuronal pathways with each other, right? And first and foremost important part we can carry out to improve the nystagmus is to stimulate the vestibular ocular reflex, right? So there can be three types. The first will be the first and second will be the stimulation, and last will be the cancellation. So we can you visually fixate the patient to ask for the stationary target and then allow the slow head movements. Then second will be visually fixate on target moving in opposite direction and slow head movements. Last will be VOR cancellation, means visually fixate on target moving in the same direction and slow head movements. Progression will be by increasing complexity to the background. So the patient will be confused, and that's how he will always try to make sure that which is normal and which things he has to consider and which things he has to avoid, right? Next will be the saccades. They are the active eyes alone, and later on combine eye and head movement between the two stationary targets. Progression can be by increasing and varying speed. Important considerations for the patient: careful monitoring for the symptoms of vertigo, observation for the postural tremor or titubation. First thing I would like to mention that the patient always should be careful for the vertigo symptoms, because if the pathology is ulnar cherry malformation, then if it is abnormally compressing upon the all the structures in the brainstem, then the patient may have vertigo, and that thing should be taken as seriously. So these things is very important, right? So coming back to the considerations are observation of the recovery from the lack of check. This is very important because patient always have this abnormality. So patient should have the this thing that he is able to regain is normal base of support, that is lack of check. Next is made him to analyze movement activity problems that are based upon the functional activities such as dressing, feeding and other activities of daily living. Adequate endurance for self-participation in daily activities, and finally, very important is rest. Because later on, as the pathology progresses, the patient will be almost dependent for all the activities, and mentally he will be depressed. On top of that, the musculoskeletal system, neuromuscular system, all it they are not working properly. So all the time the patient is feeling fatigue because not all the system are working together. So rest is utmost important, right? uh, Now important consideration for the therapist are, we have to look upon the ICF model and we have to make sure that which activities are important and which activities we have to consider for the rehabilitation. We have to slow down the movements. It will indirectly decrease the movement decomposition, which is the main problem in these patients. Next will be use vision. So we can use vision as a tool, because this with the vision the patient will able to regain the conscious control, right? And next will be, for gait, widening stance can be helpful, because with the narrow base of support the patient will lose his balance and he may fall. So that's why if the patient is having a very difficulty, then for gait training, widening stance we should allow, right? So here are the further references that can be go through it. There are that is textbook of neurological rehabilitation, Darcy and Umfred, and motor control, that is book from Shumway Cook and Wallagat. I hope you all understand. Thank you.